that came. You can also raise your hand so that we you can indicate that you want to speak and we'll unmute your mic. So by way of introduction, Shatterproof hosts a variety of educational videos and webinars, but the CQI is aimed specifically at providers of treatment for substance use disorders and is brought to you by the Treatment Atlas team. Treatment Atlas, of course, is our online platform that helps guide people to appropriate care for addiction and allows them to compare their options based on services provided, types of payment or insurance accepted, and even by patient or client reviews. Speaking of Atlas, we're nearing the end of a provider enrollment period for most of our Atlas states. So please enroll if you haven't done so, or renew by completing the enrollment survey. You can see the email address there on your screen, atlas@shatterproof.org. If you don't have the materials you need or the link to your survey, please contact us at that email address and we will get it to you. I'd like to make one more announcement before introducing the topic and today's panelists. We have 7 Shatterproof walks coming up this fall in cities across the country. We really hope you'll join us, come out and help us to honor those who've lost lives to substance use disorders and to celebrate those who are living in recovery and bring hope to the millions still suffering. To find out more information on our walks, please visit us at www.shatterproof.org. Next slide, please. Yep. Okay, so today's topic is expanding the substance use disorder professional workforce, opportunities and obstacles. Often in these CQI webinars, we cover topics specific to our Treatment Atlas platform. The first one of the year covered the importance of getting patient feedback in terms of guiding consumer healthcare decisions and highlighted our easy to use patient experience survey that's integrated into Atlas. We've also had webinars focused on the quality measures that are built into Atlas that are based on Shatterproof's national principles of care. But we've done some listening to our providers, and one of the issues, one of the topics they bring up to us and have said they'd like to hear us talk about is the substance use disorder workforce. What can we do to expand the pipeline of workers in substance use disorder care? And what can we do to retain the workers that are already in the field? And that reminds me, please, at the end of this, we're going to send out an email evaluation survey. It'll be pretty quick, but give us your feedback. And also there's space where you can let us know if there's other topics you'd like us to cover. So one of the things that I asked our speakers to do too, diversity might not be the first thing that comes to mind when you look at those of us on camera, but one of the things that I really want them to look at too is what we can do to attract more people to the SUD workforce so that we have a workforce that is more reflective of those who experience addiction and could benefit from treatment. So I'm really excited to have the 3 panelists here today, and I'm going to give introductions to all of them in the order that they'll be speaking, although I think Pete and Sherry might be speaking together, and then I will turn it over to the panelists, which is what you're here to hear. So first is Charlie Smith with SAMHSA. Charlie was selected as the first regional director for the U.S. Department of Health and Human Services for SAMHSA in Region 8, which covers much of the Western U.S., including 33 federally recognized tribes. In his role, Dr. Smith serves as the Federal Authority for Mental Health and Substance Use and represents the Assistant Secretary in fulfilling the agency's mission of reducing the impact of mental illness and substance use on America's communities. Prior to joining SAMHSA, Dr. Smith served as the director of the Colorado Division of Behavioral Health and Deputy Commissioner of Mental Health and Substance Abuse for the state of Colorado. Dr. Smith is a licensed psychologist with over 25 years of clinical experience. Next, we have Pete Nielsen. Pete is the president and CEO of the California Consortium of Addiction Programs and Professionals and has worked in the SUD field for 20 years. He has experience as an interventionist, a family and recovery specialist, a counselor, an administrator, and an educator. Pete also serves as the secretary of the International Certification and Reciprocity Consortium and as publisher of Counselor Magazine. Pete has a master's in counseling psychology. And we also have Sherry Daley. Sherry is the vice president of Government Affairs and Corporate Communications for the California Consortium of Addiction Programs and Professionals. She's been a leading addiction treatment advocate in California, where she's been instrumental in shaping policy for the treatment industry for more than 30 years. Sherry has also been published in numerous industry publications and is currently awaiting the release of her first book, Christina with a K, A Rainbow Person's Journey from Addiction to Recovery. And with that, I will turn it over to our speakers. Charlie.
Thank you so much, Grant. And it's really just a joy to kind of be with your community and kind of talk about workforces. And so thank you very much for the invitation. So it's great to be with you and to kind of represent the U.S. Department of Health and Human Services, and very specifically the Substance Use and Mental Health Services Administration, otherwise known as SAMHSA, in this conversation about workforce. As Grant had indicated, I'm the regional director for SAMHSA in the Denver office, and so I'm coming to you from Denver, Colorado, and here to talk about some of SAMHSA's efforts, as well as the work from the U.S. Department of Health and Human Services concerning advancing, supporting, and growing our behavioral health workforce. Next slide, please. I always like to kind of start this conversation as really kind of shaping a little bit of what our ecosystem is. I mean, we know that approximately 1 in 5 U.S. adults live with a mental illness, and about 1 in 9 adults struggle with a substance use disorder. And as the importance of behavioral health care access, equity, and quality grows, so does the demand for a skilled and behavioral health workforce. Individuals, families, communities really rely on accessible, high-quality mental health and substance use service delivery, and I refer to this as really our ecosystem. And as you can see represented, they're really kind of 5, 6 major components of that ecosystem, which look and function, quite honestly, differently from state to state, county to county, but as a whole, they all exist. But there's 7 core features of this ecosystem. We know that emotional health and well-being is vital to our overall health. Substance use disorders and mental illness, they're chronic illnesses. Equitable access to behavioral health treatment is a critical public health strategy. We know that the science behind the effectiveness of substance use and mental health treatment is very strong. We know that behavioral health needs to be integrated, coordinated across physical health, public health, rehabilitation and recovery support services. And we know that substance use and mental health treatment needs to be tailored to that individual, and particularly for young people, really making sure that we include families in that therapeutic process. But really the cornerstone, that kind of 7th core feature, is that a trained, competent, culturally responsive, and reflective behavioral health workforce is essential. It's the engine that makes this ecosystem really work very effectively. And developing this workforce to prevent and treat mental health and substance use disorders is one of SAMHSA's highest priorities. Next slide. So one of the things that has been very exciting, particularly over the past couple of years, is with our current administration, the Biden-Harris administration has placed a priority on issues concerning mental health and substance use. The president's unity agenda included a mental health strategy that specifically called out the need for a diverse and high qualified behavioral health workforce. The U.S. Department of Health and Human Services took that charge and really developed a department-wide plan to address the health workforce. And you can see the 4 goals that are outlined there that really talk about kind of a workforce that's meeting community needs, that there's good distribution, that we really enhance high quality and emphasize high quality treatment through professional development, collaboration, and informed evidence-based practice. And we also want to make sure that we're using data to really drive that and to really understand where their workforce is working and not. You can see the agencies listed below, and that's just some of the U.S. Department of Health and Human Services. However, HRSA Health Resources and Services Administration, they're really our engine when it comes to this workforce agenda. And many of you are likely familiar with the National Health Service Corps as one of their flagship programs concerning workforce. But they have a number of other programs that I really kind of encourage you to take a look at, one of which is a substance use disorder treatment and recovery loan repayment program, otherwise known as STAR. HRSA also stands up a nurse scholarship program. They stand up a faculty scholarship program, as well as they stand up the Behavioral Health Workforce Education and Training Grant Program, which supports not only practitioners, but also individuals who want to enter the field as paraprofessionals. In addition to HRSA, Indian Health Services, the Administration for Community Living, the National Institute of Health, and the CDC, and my apologies for all the acronyms. But as you all know, government loves its own language. But there are a number of other federal agencies that also play a role when we want to think about workforce and the strategies that you want to kind of emphasize within your communities. Bear in mind that the Veterans Administration, the Department of Labor, the Department of Education, the U.S. Department of Agriculture, and the I want to make sure I get it correct, the Economic Development Administration, all five of them play a significant role in offering funding, offering training and technical assistance to grow as well as maintain a workforce that includes the workforce supporting mental health and substance use. Next slide. So talking about SAMHSA, and SAMHSA is very much part of this departmental-wide agenda and strategy to address our workforce. As you can see on the left-hand side, those are our 5 priorities, and our 5th priority is strengthening the behavioral health workforce. SAMHSA as an agency, and having been with the agency now 12 years, SAMHSA's core effort is around workforce. I mean, we are committed to building, supporting, and enhancing a diverse, highly qualified behavioral health workforce that supports the entire ecosystem that I just mentioned. As well as we want to make sure that we recognize that there's a workforce that supports this behavioral health workforce and a lot of the work that you do. And to think about the workforce around leadership and management, supervision, those critical employees that are involved in research and evaluation, those are doing public policy as well as financial and actuarial services. Those are part of that workforce we have to be mindful of. And clearly from SAMHSA's lens, we're thinking about clinicians, but we're also thinking about these other ancillary supportive workforce elements that we want to make sure to continue to grow. When I talk about workforce strategies from the SAMHSA lens, there are really 5 strategies to focus on. One is the pipeline. How do we get people interested in the field? 2 is thinking about recruitment and retention. As much as I mentioned what HRSA is doing with loan forgiveness, there's scholarship programs, there's loan forgiveness programs, there's incentives in which we can kind of build around that workforce to attract them to our professions, to our centers, to our clinics, as well as how to retain them. We want to think about education and training to make sure that we are growing those that are in the field to maintain their involvement, to maintain their skill and acumen, as well as we know that training is an element that can retain the workforce. 4, we want to make sure that we're supporting our supervisors. Supervisors are core to not only early career clinicians who are coming in, but they also create that tenor for that clinical environment upon which many of our workforce is really looking for. Having a very supportive supervisory structure is one of those core tenets when we think about workforce development. And number 5 is really thinking about the growth and the support for our peer workforce, which is something that SAMHSA is leaning very heavily into. For our priority, we're definitely focused on active recruitment, training, and retention. We're focused on promoting those professional development opportunities, as well as increasing accessibility of the behavioral health workforce provider sector. So next slide, please. So SAMHSA's flagship workforce initiative is the Minority Fellowship Program, which at its core is designed to support better behavioral health outcomes for racial and ethnic populations. We've actually fund directly associations that work with universities to attract individuals from a variety of different backgrounds to actually come into the field of behavioral health, both in the areas of mental health and substance use. We work with those agencies that are listed actually on the right-hand side, the American Nursing Association, NADAC, the Counselor Association, the Social Work Association, the American Psychiatric and Psychological Association, to grow these fellowship opportunities for individuals from minority populations to work with minority populations within the field of mental health and substance use. In addition, SAMHSA stands up the historically Black Colleges and Universities Center of Excellence in Behavioral Health. The HBCU program recruits students for careers in behavioral health fields and provides training to lead individuals into those fields, as well as provides a direct conduit for the Minority Fellowship Program, as well as those that may not be part of the Minority Fellowship Program, again, to find great attainment for job opportunities for minority populations. And then 2 years ago, SAMHSA reignited our prevention fellowship program, and it's a substance use prevention fellowship program, which is actually functioning through 10 of our prevention technology transfer centers. SAMHSA, which I'll mention here in a moment, has 10 regions, and in each of those regions, there is a substance use prevention technology transfer center, another way of saying a center of excellence. And we're actually bringing in prevention fellows into those centers, which are typically university-based, to grow that profession and lead to prevention specialist certification. And then finally, SAMHSA does have a expansion of practitioner education grant, which actually funds universities directly to embed SUD, prevention, treatment, and recovery content and curricula into medical schools, nursing schools, schools of social work, as well as psychology, education, and training programs. And there are awardees across the country that are receiving this Prac Ed grant to support education early on. Next slide. SAMHSA has been very focused on, go ahead and next slide.
Sorry, I opened the link for your website. 1 second.
That's okay. No worries. And just to prepare the audience, the next slide is a busy slide, so my apologies on the front end.
Well, while Catherine is queuing that up, I'll just say we're going to make these slides available afterwards because there's a ton of resources on here, Charlie. So thank you.
Not a problem. So this is a busy slide. It's really a screenshot, but it's really kind of important to know, as I mentioned at the onset, practitioner education and training is core to supporting the workforce, particularly those that are currently practicing. SAMHSA has over 40 training and technical assistance centers across the country, as well as within specific regions that offer free professional development, webinar training, as well as consultation directly to support behavioral health professionals. As I mentioned, there are these 10 regions, and there are, as I mentioned, 10 substance use prevention technology transfer centers, otherwise known as centers of excellence. In addition, there are 10 centers of excellence for addiction treatment, as well as 10 centers of excellence for serious mental illness and serious emotional disturbance. They are all located across the country. They're available to you to support, to build into your organizations and your professional groups to support ongoing training and professional development to really kind of, again, continue to grow the expertise of our professions. Next slide. Want to make sure that we call out the importance of data. SAMHSA last year worked with George Washington University and developed a behavioral health workforce dashboard, which is a very unique dashboard of over 1.2 million behavioral health providers around the country. It's geocoded to the census, as well as it provides state and county specific counts of every included mental health and substance use provider across the country. You are able to kind of uniquely look at those providers that are accepting certain types of insurance, those providers that specialize, whether it's in addiction and or substance mental health, as well as the types of services they're providing. We're seeing this as a great resource available as you think about strategies and planning in your area and or states or communities for information on the current workforce. In addition, our Southeast Mental Health Technology Transfer Center, located in the Atlanta area, has also developed a behavioral health workforce shortage map, which actually coincides with population size for rural communities. HRSA tracks a workforce data warehouse that actually looks at all different types of health workforce fields, as well as we have a SAMHSA now funds a center of excellence specifically in the behavioral health workforce that does research on that workforce at the University of North Carolina in Chapel Hill. Next slide. Future focus, SAMHSA is very much keen on really talking about this role of integrated care. And many of you have probably heard about certified community behavioral health centers, and very specifically with that new model, which we now have 8 cohorts around the country, with over 500 individuals receiving funding, is really thinking about how that workforce is working within those integrated care environments and the unique skills and collaborations, and what does it mean to provide team-based healthcare, very different than as a solo psychologist providing clinical care. We want to make sure that we stay future focused on interstate compacts. Many of our professional organizations are thinking very strategically about how we can more flexibly use licenses and practice across state lines. I frequently talk about this as license portability. How can my professional license as a psychologist be used much like a driver's license? But that takes a lot of coordination from state to state, as well as support by our various accreditation fields and disciplines. We really want to think about how we value our profession, both the value of mental health practitioners, the value of substance use practitioners, the value of peers. Part of that is through making sure that we have equitable and attractive compensation. We know that compensation plays a big role with bringing people into the field and holding them onto the field. And so we want to be very attentive to how do we continue to attain and maintain that value, and compensation is one of them. We really want to leverage our workforce and partnership across the role of peers, individuals with living experience, our community health workers, and other paraprofessionals to make sure that that infrastructure is well structured and brought to the fore when we think about clinical care in a public health, clinical, as well as recovery support environment. On the right-hand side is actually SAMHSA's recent release on a peer support services in crisis care, which coincides with our role with 988, but really thinking about the peer workforce in that specific context. And then finally, thinking about the medium by which we actually deliver care. There's a lot more digital work happening, not only televideo and telephonic, but also thinking about using apps and other electronic mediums, and what the workforce needs to kind of grow in skill and comfort to really join our patients and meet them where they're at. That is a unique skill that we want to make sure that it's being married correctly with our workforce. And next slide, and I think that ends my presentation at this time, and I think I'm going to turn it back over to Grant. Thank you all very much.
All right. Well, thank you so much, Charlie. Really appreciate that. And we're just going to go right into, I believe, Pete and Sherry, you're going to be sharing your own slides. So Catherine, if you want to take this down and let them share. So thank you, Pete, Sherry, take it away. Thanks so much for being here.
I'm not sure if Pete's.
Thank you very much, Grant. I'm bringing my slides up here right now, so apologize for the silence as I bring it up. So let's see. So give me 1 second and I will bring it up. And okay, here we go. I found it.
Great.
All right.
Thank you.
And let me change just real quick. I'll bring myself on screen as well. So, so thank you for having us. And right. So I'm gonna can you hear me okay?
Yes, we can hear you, Pete.
Okay. All right, so here we go. So let's talk about, the workforce. So thank you very much for Dr. Smith, in your presentation. It's really important to know what's happening on a federal level. I'm going to give you some of the things that we've found in California and kind of give you some of the things that we're working on. And something that's really of interest is we did a substance use disorder survey that reached significant statistical significance. And we want to share that data with you. We did this last year, so coming out of the pandemic, but it's really important and pertinent to what we're talking today about workforce. And I will echo a lot of the comments that Dr. Smith said, because it was definitely well said, and we're moving forward in a positive direction. So let me move forward. Okay, so here's what we found as far as years of experience in the field when we did this survey is, so you can see that there was a large percentage of individuals, 39%, of 10 years plus. And then you had 5 to 10 years with 22%, and then 31% was 1 to 5 years, and then less than a year was 8%. And then you look at education. So it's important to know where we're at with education, especially since when we try to recruit new individuals to the workforce, what are we doing to lower the barriers to get individuals in? What are we doing at the high school level? How are we getting individuals and getting them interest in what are the barriers that they may have that they won't be able to do the work? And being able to recruit individuals that want to do the work, and being able to make it accessible to them and possible for them to be able to do the work. We need to look at that when you recruit in the high school level and in the college level to then start to build up this robust workforce. So we have 17% was at the community college certificate level, and you had associate's degree 18%, bachelor's degrees 22%, and 18% was high school degree. High school diploma, and then master's degree. And then note in California, and unlike many other states in the United States, we do not have state licensure. And so all of the individuals are working at the certified level and not at the license level, unless they have a licensed, if they're licensed in mental health, and they may have a license, but they don't have a license in substance use disorder. So then you look at this as far as what are their job responsibilities: administrative, management, and then direct patient care, 72%. And then looking at, what type of company. Is it for-profit? Is it nonprofit? Is it county-based? And you can see you have the largest percentages is county contracted, community-based, and then private for-profit. And then what type of payment is accepted. So you can see private insurance is 28%, and then private pay cash is 59%. And then Medicaid is 61%. And then here's a heat map of the responses in California. So of course, the largest body of people in California, of course, is in that lower LA County, LA region area. There's just more concentrated people, and of course, San Francisco, large concentration. But you can see that we got responses from rural areas, and I think it's important to remember that the workforce shortage and the workforce issues that we have are different in rural areas than they are in urban centers. So you can see that there was definitely we got responses from all the different areas. Of course, there's more people in those urban areas, so we got larger responses from them, but we wanted to get responses from all over the state. So you can see far up north, and then far down south, and then over towards the east part, which is more of the desolated. And also you'll see the clusters, because in some of those areas you don't see anything. There's no treatment. There's in those areas. A lot of that is wilderness area, and there's not any treatment facilities in those areas. So you'll see that big gap that there's probably very little on that lower east area or that mid east area. All right, so demand increases while the capacity decreases. So 10 years ago plus, the Office of Statewide Health Planning designated drug and alcohol counselors a distressed workforce. And now, we're beyond critical shortage. We were distressed then, but we're beyond that. And we sounded the red flags back then, and continue to sound of what can we do? And Dr. Smith talked about some of this as far as there's an incredibly demand for people wanting help. And we need to meet that demand, but we need the workforce to do that. And we need a culturally responsive, workforce. So we need to move forward in that. There's only going to get, more demand for services. And so then we need higher demand for counselors to keep up with the demand for services. So this just shows, kind of how COVID affected overdoses. We'll go into that. The pandemic, we know that the pandemic had a tremendous effect on, individuals' mental health coming through the pandemic, and we see, that it really has impacted people. So let's look at, coming out of the pandemic, people are making more money because there's a workforce shortage everywhere, not just in, the substance use disorder realm or the mental health realm. There's actually everywhere. So, people have started to make more money in McDonald's and Walmart and Amazon than they are working in some of the facets of substance use disorder. So you can see on high school, degree, average hourly, and you can see as it changes, and you can see, 10 years of experience, you see average of yearly is, a little bit above 57,000. And then you can see as far as when you look at associate's degree, and you can see that there's really a wide range of the experience and education, and then what people are paid. So I think we need to keep in mind, that we need to take a look at that and what people are made, and look at, what people are making. I mean, I know people are making, the $25 an hour at some of the foods or restaurants and stuff, and an outlet pays pretty good money, and being able to compete with that. No longer are wages at, well, in California, it's minimum wage is $15.50, but fast food's higher than that. It's $17-20, dollars an hour, maybe 25. But so we need to keep up with that, and especially since we're dealing with individuals that are skilled workers that have competency in drug and alcohol, that have to go to school. We need to to keep pace with that as far as how much we pay them. So you can see more on this in looking at bachelor's degree, master's degree, doctorate degree, and mind you that the master's and doctorate degree are not licensed in California. We change that if they're licensed, and we have been advocating for years to have a career path, and SAMHSA has some great information and is updating that career path. But I think every single state should have a career path, from certification to licensure for substance disorder counselors. And I think the same it would be nice if you also had that on the mental health side. If you had, peer support and certified mental health specialists or behavioral health specialists, and then, licensed mental health. And you can see that, in many states, it's mental health peer support, and then you have licensed, but you have nothing in the middle. And so it'd be nice to see that. I know that Wyoming has, believe it or not, Wyoming, that's my state I'm originally from, they have a certification level, and so does Oregon, and I believe Florida. But there needs to be more in the mental health, because it really helps with parity, and it helps that the individuals get treated, and it decompresses our workforce. So we need to make sure that we have we're able to decompress our workforce, because we're putting a lot of pressure on individuals that are licensed, and we don't have enough people. So we need to have more people inside that career path, both on mental health and both on substance use disorder, because that will help decrease burnout, that will help to spread the workload, and that will help create successful infrastructure. So, in California, we have registrants, and this is what registrants get paid. And you notice that some of them are creeping up to what the certified get paid. So that needs to be changed, where, that they don't have the same education, but that yet they're getting paid just as much. That definitely needs to be focused on in the next year, and having licensure and stuff would definitely help kind of ferret a lot of that stuff out. So more stuff on how registrants, and they have up to 7 years with a hardship to become certified, but they have to become certified. And then you can see certified. So the other thing is supply and demand, and that is when you look at where are we at in California as far as treatment capacity. So that it definitely impacts. One is there needs to be higher reimbursement rate for treatment programs, especially county funded ones that are through Medicaid and the county system, to be able to meet the demand. Also, those contracted providers that provide services for the county, because the county also employs substance use disorder counselors, and they can pay benefits, and they can pay a higher wage. But then so also the contractors for the county need to have higher reimbursement, and they need to and be able to pay the individuals higher. So that's something that we're advocating for both, that we want to see that higher reimbursement for the facilities, so then they can turn that around and pay the professionals that work in their facilities more money. And also we really need to look at network adequacy, meaning we need a treatment on demand system in California, and we don't have that yet. We are lacking in network adequacy. So here's some demographics that we found, and so here's where it's a difficult conversation, because we don't have the individuals that we have working in the profession do not match the individuals that they serve. So we need to do better at getting more trans and non-binary counselors, more LGBT counselors. We need to also work on getting more counselors that are from the community, such as the African American community or the Native American community, to work with their community, inside their community. That would decrease a whole lot of barriers for individuals seeking treatment. And I think also we have 24% are Hispanic and Latino, but I know that not all of those speak Spanish, and we have always a high demand for Spanish speaking counselors. But we have the population is a lot higher as far as Hispanic and Latino, and we lack the amount of workforce to meet that demand, so that the individuals can that we can match those of the individuals we serve. So age is the other thing. So we look at it and we see, so where is our, age range of our most, our highest workers in, and you can see that the 18 to 27, we're definitely lacking. And we know that we're getting more young people into treatment that need help, but we only have 8%. Bet you we have more than 8% that are in the age range of 18 to 27 getting help. And look at this, in the next 15 years, the workforce will be retiring out. And where are the individuals to be able to replace them? That's the scary thing. All right, so with that, I will turn the remaining part of this. I'll stop screen sharing and I'll turn the remaining part of this over to Sherry. So thank you, everybody. And it was great to be on this webinar.
Thanks so much. And while Sherry is queuing up her slides, I will just say we've had a couple of questions about where can I get the slides. Where anyone who's registered, we have your email address, so we're going to send out the slides. I think we will have a link to the video afterwards, and if the participants don't mind, we can send a copy of the transcript as well. So.
Thank you. I didn't mean to change the screen that fast. Appreciate the setup from both of the previous speakers. Really important to understand what we're facing to begin with. I'm going to go over some things that are what I think most of you came on here for is, okay, we've discussed the problems. Now let's talk about some solutions maybe, and California has some really good ideas. So I want to go over some of them and kind of bring this back around as a nice ending to how we've progressed through the presentation so far as to what can we do now, given our resources, given what's going on, how can we affect change in the short term and also in the longer term. So my thing's showing here. Can I turn that off? Oh. I don't know how to get that off of there. Okay, so I'm going to focus on 3 areas today: the professionals, resources, and systems. So we're going to start with focusing on the professionals. So it's really important, I guess I can move that. There we go. I learned to know your professionals' needs. It sounds kind of dumb as a place to start, but really that's where we need to start. I can't tell you as an advocate how many meetings I go to where we're all talking about what should we do? How can we increase access to care? How can we widen systems? How can we stop the opioid deaths? And there's not a single counselor in the room. No one's asking them what they need or what they feel or how they think things should be changed. So it's super important to know your counselors and what they are looking for in their jobs. There we go. So first off, they are passionate and they are sensitive. So when we're talking about things as bland as career ladders and parity, these things really matter to this workforce. So when you're looking at small steps and increasing your professionalism of going from maybe a registered counselor, certified counselor, up to a higher level of certification or to licensure, those are really important moments to celebrate and to really call out in your organizations that those are important to those individuals. Parity also is huge. Our workforce does not like being called ancillary or support staff. All of these words express to them that their expertise, their commitment, their level of ability to affect change in an organization isn't as strong as they feel it is. So parity really matters. And on a policy level, if organizations are pigeonholing experts in substance use disorder or counselors who specialize in that type of treatment are not given the same sorts of titles, pay, recognition as those in the mental health field, we're baking in sort of a lesser than, and it comes from stigma. And our counselors really do feel this, and we've heard this numerous times when we're talking about what could make things better in our workspace. Also, there are some low-level things that are cost efficient that can be done that make our workforce feel more connected, feel more valuable. And one of those things are specialty credentials. They really work. So if someone shows some some aptitude in women's treatment, medication-assisted treatment, LGBTQ. Investment in that interest is really important. You can help that person with education and certification for that specialty, call them out, recognize them for it, allow them to share that expertise and competence with others in their workplace. And then mentorships are really important. As I said, our workforce is very sensitive. They are relationship people. They're not accountants. They went into this field for a reason because they like interactions with people. So it's really, really important that especially our younger parts of the workforce feel connected when they come on board. And of course, the whole work from home and telework and telecounseling is impacting that ability greatly. So keep that in mind. And then finally, work stress is real. I can't tell you how much the overdose crisis is affecting our workforce. We often think of nurses during COVID and doctors during COVID and all of the death that they had to deal with and the trauma levels that impacted those professions. We aren't kind of catching up to that speed with our counselors. They also are facing lots of trauma given the amounts of overdose in their profession right now. So keep that in mind. Self-care is underutilized, it's underrated. Organizations really need to recognize that to retain workers. So let's focus on resources. I won't belabor this because we all know that the way to keep workers and gain workers is to pay them more. And we are oftentimes treating our treatment system like it's a charitable organization. And I don't mean that in the nonprofit sense, but in that somehow our organizations are supposed to do more with less because we are in it for the long haul, because we care about our clients. So we should do as much as we can with so little, and that has to change. We have wage competition, as Pete pointed out, from the private sector, from other industries. We need to spend more time forecasting. There is so much that is done at the state policy level that doesn't take into consideration wage pressure. And we need to hold our policymakers to their word. Everyone from the state level, the county level, the national level is yelling on the mountaintops about deaths from opioids, but when it comes to funding, we just don't see that come through. So you as individuals on this webinar, if you get the call to come to advocacy, to show up for a hearing, to write a letter, please do. It is all of our business that we hold policymakers to their word regarding resources. Also, our private pay faces the same sort of shortages of resources. You would think that in the private pay system, there's this flood of cash that they can hire anyone they want. No, they are also under resource management problems. When we have doctors who are declining claims at 90% rates, this is putting a resource crunch on our for-profit providers as well, and that leads to not being able to pay people wages that keep them in our workforce. So this is all related. The larger issues of can people access care? Are there resources entering the public and the private systems in measurements that allow us to hire the workforce we need is a question that should be on all of our minds and should be addressed. And then finally, we need to look at how the behavioral health, and I'll put that in air quotes since you can't see me, but behavioral health is a term that's supposed to include substance use disorder and mental health. But in my practical experience, many times the substance use disorder end of that situation is shorted. And historically, substance use disorder has been underfunded compared to mental health. So it's important that in a behavioral health budget, that behavioral health budget has a larger percentage for substance use disorder. It seems unfair, it's not. Substance use disorder has been underfunded, so we need to do some catching up and make sure that funding within the behavioral health budget has slightly higher levels for substance use disorder in order to fill those voids. So let's look at quickly at focus on systems, whether they are creating barriers or helping our counselors to get in and return to their jobs. So first off, do potential applicants understand the requirements? Our requirements are different than other professions. Sometimes they're difficult to understand, comprehend. They aren't clear. Different parties are communicating what the standards are. We have boards, we have public sources that have standards. We also have schools that are communicating. That's very confusing for our entrants that are coming into the field to try and figure out, where do I fit in all of this? And am I able to enter the field? So that needs to be worked out. Also, can applicants afford entry? Our workforce is unique in many ways. Some of our applicants missed some of their primary areas for getting a college education. So they are at an age where they are having to self-support while obtaining education. They're second timers many times. So can these applicants really afford not only the education, but the cost of entry? So some states have been working on this. Oregon, for example, received some grant funding. That state paid for all of its SUD counselors for their initial application fees and for the renewal fees for 2 years. And that just took so much pressure off of that system. And it seems kind of not intuitive, but when you're looking at a $500 fee for license or for certification for the test and or for renewal and CEs, and you're making, like Pete said, $15, $17 an hour, that is something that may cause you to exit the system. And then finally, we need to streamline our programs to get people back. As I stated, this is a very stressful career. People come and go. So we need to be sure that having the ability to get your CEs, get your credential back in a valid status is easy to do, because we're losing really good counselors who are willing to come back, but then they decide to come back and they look at, oh my gosh, it's going to take me 6 months to a year just to get back to where I can go to work. They haven't lost their competency, but they may need to do some things to get their credential back in order. And we need to make that as easy as we can. So I'm going to end this conversation with just an example of what California is doing, which is super innovative. It's called the Learn and Earn model, and we think it's worth duplicating. So we received a grant from the Child Youth Behavioral Health Initiative, which gave us $5.4 million for a 3-year grant. And what we're doing is we're paying our applicants to work while they go to school. So this isn't new. We've seen these in other fields, but we're giving a $2,500 a month stipend for 20 hours a week work and 20 hours a week in an education setting. And that's our vocational school. In that 20 hours, we reduced the 18-month time period it normally takes a person to get through school, because we're paying them to go to school. So we reduced it to 1 year. So they're working and going to school full-time, basically, with a stipend. We pay for all of their education, their testing fees, their application fees, and we give our programs financial incentive to take these students, because they don't have experience, they're still learning. So it's difficult for some organizations to use those workers, but we're incentivizing them to do so. The second part of it is that we're providing an immersive experience, which we think will really allow these students to become long-term participants in our workforce. We have given them each a budget of $2,500 where they can go to learning collaboratives, conferences, events that appeal to them. So we've divided our students up into different cohorts. For instance, an LGBTQ cohort, a Native American cohort. So they will get to go to things that are important to them. And this augments that online learning. Our people are touchy-feely. They want to be involved. So we put this component in so that they could experience on the ground interactions with other counselors in the field where they are interested and excited. They get a complete specialty credential too with this program. So they end their program. They are not only have their base certification, they have a specialty certification that makes them more marketable and is exciting to them. And we have paid placement services, so they will have a job when they finish this program. And then finally, we have paid mentors in those designed cohorts. So each of the students will have somebody to mentor them along who has lived experience. This allows us to address gap populations, both rural, LGBTQ, different language groups. So we put these students together with somebody who has that ability to help them. For instance, a Spanish-speaking mentor who can help do the test prep, help them to get ready for that test, speak to them in their native language, but also not translate because they don't know how to speak English, but help them understand the dynamics of some of the types of questions they will be seeing and how that translates into how they think. So it's just a really exciting opportunity that CCAP is very thankful for having. We're very thankful that the state is supporting us in, and we think will be very successful. We have a lot of grant funding coming through. Our state is super supportive. We've got a tax on millionaires, that's Prop 63, that they are going to open up now for SUD treatment. We have some pass-throughs in a new mental health. It's called BH Connect. It's community-based organization of networks of equitable care, which we will get some workforce money from that. And then we had a mega behavioral workforce budget, which was $1 billion that passed through the budget process last year, which will also provide for workforce. So if you're from California, it's on its way. It'll take a while for it to get out and roll out, but our legislature has listened and lots of funding is coming, including this Learn and Earn. So with that, I will look at the Q&A and I'll turn it back over to Grant. And thank you so much, Grant.
Well, thank you so much, Sherry and Pete and Charlie, and best laid plans. I thought we were going to have more time for Q&A. We do have a few. I just wanted to summarize some things in the, I mean, there was a couple of comments from Wisconsin. Welcome, Wisconsin. We're launching Atlas tomorrow, I believe. Yeah, we have a problem with delays in licensing for people and organizations up to 6 months. And there were a couple of comments, including Alex Shohit too, about, can we work with CCAP? And there was a comment from Wisconsin, what can we do at the state and federal legislative level? And we do have, I believe it's Miranda has her hands up, so to speak. So if you could unmute her, there you go. Go ahead, Miranda.
Well, it's still morning here in Wisconsin, so good morning. Thank you very much for the information that you shared. It's very timely. I know for us, we have actually reached out to what's called the Wisconsin Hospital Association to just start to do some advocacy on this. So this is very timely. Anything that you can share with us, I love to hear what's going on in California. It seems very, very great. I think it should be translated into other states then too. So if it's okay, would it be things that we can use what you have already gathered so that we can bring that forward with what we have going in Wisconsin as well?
Yes.
Sure. And we don't mind providing you the questions for our work survey, because that we ran into that problem with our policymakers. Well, we don't see a problem. So when we outlined it, said we see a problem because 36% of our workforce is about to right off into the sunset. So, and here's what we're paying them. That's they do
Correct.
they do these surveys of behavioral health, and they never drill down to what are SUD counselors being paid. It's nowhere. We found it nowhere. And California collects a lot of data. So CCAP under Pete's leadership just said, no, we're going to do our own survey and we're going to do it statistically significant. And it took a lot of time and resources, but we got it done, and it gave a clearer picture of what we're facing.
Are you willing to share those questions and how you did it too?
Yes.
Yeah.
Yes.
Awesome.
And the key thing too is we were able to give that information to our state regulators, to HCI, and we gave that to them free. We shared information to help them. So, and we think that would, it informs people more if we can share information. So they were happy to take the information, and it was a great collaborative between us and the state regulators.
Miranda, this is
Absolutely.
Charlie. You may also want to lean into, I believe the University of Wisconsin has SAMHSA's Addiction Technology Transfer Center grant, and they would have they would have access to resources to potentially even stand up a survey that may be unique to the addiction workforce in Wisconsin, as well as obviously an intimate ally of yours, and thinking about kind of growing that. So that may be an ally for you to pull in.
Awesome. Thank you so much, Charlie.
Yep.
Right. Well, like I said, I love that part, and I love that providers from different states are connecting with Charlie from the federal government. Wish we had more time at the end. I want to be respectful of our panelists. Let me just check, Catherine, any last burning questions from participants?
I believe you mentioned this, but Alex did ask if it was possible to collaborate with CCAP to expand the classes available.
All right. I'm seeing a nod of the head, yes. And panelists, let me just ask by nod of the head, when we send out materials to the registrants, can we also include your email information so if people want to follow up with you?
Absolutely, from my end.
Okay. And all of you, I should note, I found them by myself sleuthing online. So you're out there, you're public. Well, this is great. Like I told the registrants, we will send out to you the slide deck. I believe we will have a video link for you. I'm not positive on that, but I think we can get you the transcript as well. You'll have our email addresses, the panelist email addresses, so you can follow up with us or with them. Thank you so much. And really glad you could spend time with us today. big thank you, Charlie, Pete, Sherry. Thanks so much for being with us and sharing just so much. We could probably spend another couple of hours on this, but
Yes,
obviously
thank
timely
you.
and of interest. So thank you all. All right.
Thanks, Grant.
Thank you.
Thank you very much.
Sure. Catherine, do I have to do something to end officially?
Yes, let me just stop the recording.